Self off mute there. Thanks, Troy. So, hi everyone. My name is Christina Saudi, and I work with the Center for Collaboration, Motivation, and Innovation, which is a non-profit founded in BC with the mission of fostering empowered partnerships, building helping skills, and creating responsive systems that improve health and well-being. Today's webinar is about patient and family-centered care, and it's made possible through the support of Patients as Partners, which is an initiative of the British Columbia Ministry of Health. Before we get started on the topic for today, I want to hand it back over to Troy, who's going to review some of the features of GoToWebinar. Take it away, Troy. Well, I guess I have to forward the slides, don't I? There you go. Ooh. There you go.
Perfect, thank you. So for those of you who are joining, who have joined the other webinars in the series, this will be a review, but if you're new to this, what you're looking at right now is maybe what your desktop is going to look like, depending if you're on Mac or if you're on PC. It might look slightly different, but more or less, you have a main window where you're watching the presentation right now, and on the right-hand side, you'll have a sub-window, which is the control panel for GoToMeeting and GoToWebinar. So that control panel might be large, like you see on the right here, or it might be just a small sliver of a bar. And if it's just a thin bar, you need to expand that by using the orange arrow. And Christina, if you could go to the next slide. Thank you. And so there's the collapse and expand orange arrow that I'm speaking of. And this will basically move that control panel out of your way so that you can view the entire webinar without it being obstructed by the control panel. So that orange arrow is going to be used throughout the webinar. You can open it, you can close it. And the next thing that I'm going to speak to is the question box, and it's down below. It's the second red box there. And that question box is going to be really handy today. I think during this webinar, we have 3 opportunities for participation for all of you to ask questions and put them into the box there. We really appreciate any question that you can put in there, whether it be of technical nature that you need help, or really if you have a question that pertains to the webinar, this is where you'll drop it in there. And like I said, there's going to be plenty of opportunity today for you to drop your questions in there. And I will forward those on to Christina, and she will voice them during the webinar and at the end of the webinar. So that's going to be a really useful feature. And now the third and final feature that I'm going to speak to today is the handouts. And that's not on this slide. It isn't really highlighted. But if you look in your control panel, you're going to see an expandable box that says handouts. And if you click on that box, you'll see that there's a handout in there. And that handout is called Definition. So if you click on that to PDF, it'll download to your computer. If you want to do that right now, that's great. You'll have it on hand. And this handout is going to be available here as well as on the website when we're done today. And I think that's basically it for the housekeeping. Christina, go ahead.
Thanks, Troy. So, hello everyone. As I said just a moment ago, my name is Christina Saudi. I'm a quality improvement improvement advisor that's been working in BC for the last number of years, and I actually worked with CCMI since the first pilot of brief action planning back in, I think it might have been 2012, which is where I met Bernice. And Bernice, I will let you introduce yourself.
Hello everybody. Yes, my name is Bernice Johansson. I'm a registered nurse, brief action planning master trainer, and one of the faculty with CCMI. And I'm joining you from New Westminster today. And I think we're ready to go to the next slide. So thank you very much for taking the time to participate in the webinar. We're looking forward to sharing with you some thoughts around patient and family-centered care today. Now I'll turn you back to Christina.
So in 2014, the Ministry of Health setting priorities for the BC healthcare system document providing patient-centered care was the first of 8 priorities. To further develop the definitions, key concepts, goals, and other documentation, the Ministry developed the PC Patient-Centered Care Framework in 2015. The patient and family-centered care concepts in the framework are meant to support the 5 areas of the strategic focus for the Ministry of Health, which you see on your screen. And they are improving the access to primary care through primary care homes model, reducing demand on hospitals by improving care for seniors, reducing the demand on hospitals by improving care for those with mental illness and substance use issues, and improving access to surgical services and improving the delivery of rural health services. This webinar today is focused on patient and family-centered care, and it's part of the work towards an overall improvement in the quality and sustainability of the BC health system, and it works across all 5 priorities. These patient-centered care quality improvements will affect the experience of care and lead to better health and sustainability of the healthcare system. So more specifically, what are we talking about today? Patient and family-centered care is really about voice, choice, and representation. It includes the relationship between patients, their families, and other caregivers with healthcare providers. It's also about patient self-care and prevention, and about how patients can provide their voice and experience to healthcare decision-making. The presentation will focus mostly on the relationships between healthcare providers and patients' families and their caregivers. And we're going to talk about a few specific things within that framework. The first is, what is patient and family-centered care, and what does it mean to you? And we're actually going to share a few different definitions around that and how they might be similar or different. We're going to talk specifically about patient and family-centered care and how it's being approached in BC and how it links with a few key initiatives and priorities that are currently underway. And we're going to talk also about how patient family-centered care supports self-management and links to some of the other topics that you've been hearing about if you've been part of the webinar series. And it's not up here, but we're going to leave you with, at the end, a few kind of tools and ideas around how to get started if you wanted to start looking at patient and family-centered care from the viewpoint of what you might be able to do within the services that you work in every day. So before we get started, we actually wanted to take a minute to allow some reflection around what patient and family-centered care means to you. And so we're actually going to do an entire minute of silence and get you to just think about, what does patient and family-centered care mean to you, and write that in the question box, and I'll be able to get a couple of those responses and summarize them based on what I see. So we'll give everyone about a minute to think about that, and then we'll move on. So as you sort of finish up your thoughts on what patient and family-centered care means to you, Bernice and I thought we would share with you a few of our reflections in creating this webinar. So to me, when I think of patient and family-centered care, I actually think about it from the perspective of the times that I've been a patient myself. And it means to me that the care that I received is geared towards helping me take as active a role as I am comfortable and able to take at the time. And it strives to reduce the barriers to care that are physical, cultural, and psychological, and supports the inclusion of my family in a healthy way. So it really helps me to be as involved as I can be, and helps me to encourage my family to be involved in the same way. And Bernice, what about you?
Okay, so for me, thinking about it as a care provider, patient and family-centered care means listening to a patient and their family and truly understand and respect their wishes. So working with them as a partner in care.
Great. And there's some really fantastic things that have come from all of you in the questions pane. A number of references to ensuring that client preferences are recognized and included in the care plan, seeing the client as the expert, being able to collaborate with clients and their family members, asking and listening to patients in terms of their wishes and their decisions around care. Having care directed by patients and families. So a lot of really good sort of personal definitions around making sure that we're working, this one's perfect, working alongside patients and their families, and meaningfully and intentionally including them in their care, not making assumptions about them and what they might want. That is a fantastic definition. So thank you for all of you for including all of those. And I think, we can really see that a lot of what, for myself and Bernice, what comes through when we think about patient and family-centered care, it's similar for you, which is great. It means we should be able to have a good discussion today on the webinar. So Bernice, over to you.
Great. Yes, thanks. So yes, those were great great input from you all, and thank you so much. So now we have some definitions to share with you. And you'll see as we go through that there's different terms being used. There's patient, client, person. So depending on the context of the definition, those words have been used interchangeably. So these definitions are also in your handout, which you can print off. So here is the definition put forth by the Ministry of Health in BC in 2015, and it refers to a service built around an individual, so not the provider and administration. So it puts patients at the forefront of their health and care, ensures that they retain control over their own choices, helps them make informed decisions, and supports a partnership between individuals, families, and healthcare service providers. Patient-centered care incorporates the following key components: self-management, shared and informed decision-making, an enhanced experience of healthcare, improved information and understanding, and the advancement of prevention and health promotion activities. So patients, families, and caregivers are partners in healthcare. They're supported and encouraged to participate in their own care, decision-making about that care, choosing their level of participation in decision-making, and quality improvement and healthcare redesign. So we're going to move over to the next slide, which has a definition that Accreditation Canada uses. So you can see patient and family-centered care is not just BC-orientated, it's moving across nationally. So here, family is included right in the title, as well as the broader term of client to include either a patient or a resident. So it's an approach that fosters respectful, compassionate, culturally appropriate, and competent care that is responsive to the needs, values, beliefs, and preferences of clients and their family members. It supports mutually beneficial partnerships between clients, families, and healthcare service providers. So client and family-centered care shifts providers from doing something to or for the client, where the healthcare provider's perspective is dominant, and it shifts to doing something with the client, so the healthcare provider and the client have a true partnership. So our next definition on the next slide is the version that CCMI is using. It's a plain language definition using the term of person, and it's based on the principles and attitudes for person and family-centered care. So here, guided by the person's values, strengths, ideas, and preferences in a compassionate and respectful partnership that makes certain that personal choice and informed decision-making shape how care is planned and delivered. It focuses on the person and their self-defined family to the degree they choose. So it's also important, though, to consider that patient and family-centered care is one consideration in providing care. Quality issues about care include health care being safe, effective, equitable, timely, and efficient. So the balance between patient-centered care with what is often considered optimal or quality care can certainly be complex. Healthcare providers who work in primary care, home and community care, and other settings often face the dilemma of providing care that is both person and family centered and is also safe. So, for example, people can make choices where they choose to be living at risk. There was a 2014 report by the Office of the Seniors Advocate, which documents findings from an engagement process with seniors. One of the issues seniors raised was the lack of respect for the decision-making ability of seniors. It is acknowledged that healthcare providers need to consider questions such as competency and vulnerability when patients choose to live at risk. The principle of respect has been embedded in healthcare policies such as Fraser Health's corporate policy on supporting residents to live at risk in residential care and assisted living. The health authority acknowledges that individuals have the right to self-determination, including the right to live at risk, with the patient's choice being limited by the possibility of risk to others. The Canadian Medical Association's Code of Ethics also states that responsibilities to the patient, including respecting the right of a competent patient to accept or reject any medical care recommended. So the issues are complex, and there's no easy answer to some of the dilemmas we face in healthcare, but using principles as a guide can help everyone involved communicate with what's important and needs to be considered in any situation. So we're going to move now, and I think Christine is going to talk about this audio tape.
Yeah, thanks, Bernice. So we thought while we were talking about patient and family-centered care, that we would share with you an audio clip from Dr. Dawn Berwick, who has been a long-time quality pioneer and champion for patient and family-centered care, and was once the head of the Institute for Healthcare Improvement, which has done a significant amount of work in this topic. And he talked about his own feelings around patient and family-centered care in a 2009 plenary that he gave at an international conference. So we're going to play that for you just as his perspective as someone who's not only been a patient himself, but also is a pediatrician. So he has sort of both sides of or can consider both sides of the experiences in delivering care. So here we go.
Partly that fear comes from what I know about technical hazards and the lack of reliability in care. Today I have bone-on-bone pain and osteoarthritis in my right knee. I can no longer jog, which was my passion, or even run 4 steps because I had an unnecessary and now fully discredited knee operation as a medical student, an operation that had never been subjected to proper evaluation for a condition that had never been subjected to a hands-off arm of a clinical trial. My best friend had a severe post-operative complication from a drug dosing error at transition. It almost killed him. My research on errors in care show these errors to be terrifyingly the norm. But the honest truth for me is that the errors and unreliability of healthcare are not the main reason that I fear that inevitable day on which I will become a patient. For in fighting those enemies, errors and unreliability, I am aligned with the good hearts and the fine skills of my technical caregivers. I can use my own wit to stand guard against them. What chills my bones is indignity. It is the loss of influence on what happens to me. It is the image of myself in a hospital gown, homogenized, anonymous, powerless, no longer myself. It is the sound of a young nurse calling me Donald, which is a name I never use. It's Don. Or for her, maybe it's Dr. Berwick. It is the voice of the doctor saying, "We think," instead of "I think," and thereby placing that small verbal wedge, the pronoun "we," between himself as a person and myself as a person. It is the clerk who tells my wife or my son to leave my room, or me to leave their room, without asking if we want to be a part. A close friend called a clinic for her mammogram report, and she was told, "You have to come here. We don't give that information out on the phone." She said, "It's okay, you can tell me on the phone." And they said, "No, we can't do that." Of course they can do that. They choose not to do that. And their choice trumps her choice, period. That's what scares me. It scares me to be made helpless before my time, to be made ignorant when I want to know, to be made to sit when I wish to stand, or to be alone when I need to hold my wife's hand, or to eat what I do not wish to eat, or to be named what I do not wish to be named, or to be told when I wish to be asked, or to be awoken when I wish to sleep. You can call it patient-centeredness if you choose, but I suggest to you this is the core. It is that property of care that welcomes me to assert my humanity and my individuality and my uniqueness. And if we be healers, then I suggest to you that that is not a route to the point. It is the point.
So I'm just going to get myself plugged back in here after that. We had to do some fancy computer gymnastics in the background to get that to work. So hopefully that went off for you. So I think feel free to kind of write into the question pane some of your thoughts after listening to Berwick. But I know, Bernice, do you want to share some of your thoughts around what you were thinking? Oh, Bernice?
I'm sorry, I'm talking here and I've got myself on mute, so thank you. Yes, and please we'll share the thoughts that you've written in the chat box afterwards. But sort of my thought is just that empathy can sometimes be beaten down in day-to-day clinical care, and as healthcare professionals we may feel rushed because we have many tasks to accomplish. But if we think of the care we provide from being on the receiving end of care, would we do things in the same manner? And that's what I think Dr. Berwick is saying to us. How can we shift control and power so that we have more of a partnership with our patients and clients?
Thanks, Bernice.
What about you, Christine?
Yeah, well, I think, it's interesting for me. This is actually the second of a couple of videos or audio clips that we watched for this session, and all of them centered around this dichotomy of the care provider being the patient or reflecting on their wishes if they were a patient. And I think that being able to hold both sides of the system in your hands at one time and reflect on that is a very interesting position. And of course, you would never wish ill health on anyone, but it is something that could open our eyes to what it's like to experience care from the recipient's perspective as opposed to the provider's perspective, which is impossible. You need to be in someone else's shoes if we haven't had those experiences. And I think a lot of the clips that we review also focus often on acute care, and one of the things that kind of makes me think is how might the experiences be similar or different in sort of extended primary or secondary care relationships where we are building a relationship with somebody oftentimes from a young age through to hopefully a ripe old age, sometimes with sort of chronic issues that have to be managed over time, and how do we ensure that that relationship is strong and respectful of both parties and really allows us to be who we are along with the various sort of health considerations that we carry, but not let them define us in our interactions with the system. And so I think looking at some of the things that are coming through, there's a number of people that have said that they've been talking about this, and there's good examples. And I think if you are interested in sort of pulling some of these clips, there's actually a number of them that we can send out afterwards that are where people have sort of documented some of their this sort of dual role of provider and patient and what that feels for you. So fantastic. And keep on typing things in. We'll keep checking back in with some of the comments that you're making and look at how we can move them forward as we move through the webinar. Oh, get this out of here. Okay, so patient-centered care. Oh, my little question pane keeps popping back up. So patient-centered care, what is it? What are some of the elements in patient-centered care? And Bernice mentioned these briefly when she talked about the definition of patient-centered care in BC. And so I'm just going to quickly bring them back up again to reiterate them. There are 5 aspects that are front and center when it comes to patient-centered care. And those kind of fall within the area of key components. The first is, are you going to work, Mr. Slide? There we go. The first is self-management. The second is shared and informed decision-making, an enhanced experience of healthcare, improved information and understanding, and the advancement of prevention and health promotion activities. And these all come from the BC Patient-Centered Care Framework of 2015. Each one of these areas can unfold into an entire body of work, and they're all interrelated with each other. And I think you see, if you've been involved in some of the webinars up until now, you'll see how some of these topics become sort of bodies of work unto themselves with specific tools that we use to try and move them forward in whichever area we're practicing in. But patient and family-centered care is really something that's the bedrock that underlies all of them. That what we're trying to get to is that experience of care that really makes people feel that they are the star of their experience, and that within reason we're able to wrap the care around them and have it reflect the things that are meaningful to them in a way that makes sense to them and based on who they are and where they are at the time. So what the and in terms of patient-centered care, there are a few key principles that go along with it. They have been included in many of the frameworks, including the BC Patient and Family-Centered Care Framework, and this one is actually from the Institute for Patient and Family-Centered Care. So the key points are that the person is in the center, but they're surrounded by their family and their supports in a healthy way. So when we talk about principles, that's why we don't necessarily just talk about patient-centered care or person-centered care, but we talk about person and family-centered care. And I know there's some groups within BC, like the Family Caregivers Network, that are really helping to champion this in different ways. When we look at what surrounds them, the respect and dignity is the first of those principles, and it really helps to listen to and honor people and families, particularly their perspectives and choices. Knowledge, values, beliefs, and cultural backgrounds are all incorporated into the planning of healthcare delivery as far as possible. The second principle is around information sharing and helpers communicating and sharing complete and unbiased information with people and families in ways that are affirming and useful. People and families receive timely, complete, and accurate information in order to effectively participate in care and decision making in a way that makes sense for them. The third principle is participation, and what that alludes to is people and families and being encouraged and supported in participating in care and decision making at the level that they choose. And then the fourth piece, the fourth aspect here is around collaboration. And here is where I think we get into sort of a level above sometimes individual care, and we talk about people and families being included at an institution-wide basis, collaborating around policy and program design, implementation, and evaluation. As well as education and other areas of care. And I think within BC, we've actually done some really amazing work over the last decade in supporting patient voices for programs like the Patient Voices Network and other organizations that exist to support patients and their families to be involved in healthcare in different ways. And they're really helping us be able to move forward this portfolio provincially. So this little pane keeps coming up for me. You guys, there we go. Okay. So in terms of patient and family-centered care, it's also a concept that is central to the triple aim. And the triple aim is a framework from the Institute of Healthcare Improvement. And I think if you've watched other webinars, we talk about this often. And it's being used by patients as partners as well as many other healthcare jurisdictions. Patient and family-centered care links closely to our experiences of care, but it also relates to the health of individuals and the population by helping them to be active, engaged members of their care teams. So it's both philosophically the right thing to do, but there's also evidence in the literature, particularly around self-management support, that shows that improvements in all aspects of the triple aim by really paying attention to how we're designing and delivering a system that is patient and family-centered. So sort of the third area to highlight in terms of how this relates to initiatives and focuses within the province at the moment is around how it really is core and central to some of the really great work that's happening around integration and integrating aspects of the system, especially when it comes to primary care. The General Practice Services Committee, which is a joint committee of the Doctors of BC and a Ministry of Health, has presented a plan for co-creating the future of integrated care, and it really centers around the idea of patient medical homes or primary care homes, providing supports for patients and families and linking with specialized services that are consistent with the stepped care self-management support. To drive and provide care in a coordinated fashion, the care wraps around the patient and families in a medical home model. And this is inherently patient and family centered, because what it does is it tries to ensure that we as consumers within the system, people accessing this care, are having the most seamless experience possible while integrating with multiple systems. And I think really moving to recognize that the more we can wrap the care around patients and their families, the more effective it's going to be, not only for the people experiencing the care, but also in delivery as well, because it becomes a much more efficient way for us to work with our patients, but also to work with each other as we move forward in the system. And there's various ways in which this is moving forward in different ways in BC in different areas of care. So Bernice, I'm going to hand it back over to you to talk explicitly about how patient and family-centered care connects to self-management support. And you might be on mute again.
Thank you. So we'll spend a few minutes talking about this now. So if we go to the first slide. Okay, so Christina talked about the 4 caring principles of patient and family-centered care. And those are respect and dignity, information sharing, participation, and collaboration. So additionally, the framework describes 5 care components of patient-centered care, which include self-management. So you can see self-management is at the top, as well as shared and informed decision-making, enhanced experience of healthcare, improved information and understanding, and the advancement of prevention and health promotion activities. So what is self-management? We've got our next slide here. So just want you to take a moment as well to type in the chat box. So when you think of self-management, what is this? So it's common language in medicine. It's like knowing how to manage diabetes between doctor's visits, but it can mean so much more. And we do it all the time. So self-management is a language used often in conversation and in the medical field, where it can mean many things, like knowing how to take care of your own high blood pressure between visiting the doctors. The definition of self-management adopted by patients as partners in self-management relates to the task that an individual must undertake to live well with one or more chronic conditions. So these tasks include gaining confidence to deal with medical management, role management, and emotional management. So you can see here it says the things we do for ourselves every day, the things that keep us healthy, the things that make us feel better, the things that keep us safe, the things that keep us connected, and other things. Are there any comments there in the chat box to share, Christina?
None yet, but I'm sure some will come through, and I will read. I'll give you a little flag when they do.
Okay. So, however, as a broad concept, we all self-manage every day for all sorts of things. So much of our lives happen in between visits with professionals who connect us to resources, support us, and check our health or safety status. So self-management is the things we do for ourselves every day to maintain aspects of our health or well-being, like walking to stay active, journaling to clear your head, calling a friend, or mindfulness activities to reduce stress. So self-management support, which I think is the next click on the slide, is the things that we do to help others to care for themselves. So it's like brief action planning, which you heard about last week. Brief action planning helps us help people to get stronger at supporting themselves. So if we talk about the next slide, goes to many of you have heard about the spirit of motivational interviewing in previous presentations, and the spirit of motivational interviewing is consistent with a patient-centered approach. So just to review, motivational interviewing is a collaborative conversation style to strengthen a person's own motivation and commitment to change. We're not going to be talking about motivational interviewing today. This underlying spirit is very useful when thinking about patient and family-centered care. And the spirit of motivational interviewing is described by Miller and Rolnick, who are the founders and researchers who established this approach. There are 4 things that make up the spirit of motivational interviewing. And the first one is compassion. So it's caring about what's important to another person and feeling moved to help. The second one is acceptance, respecting another person and their right to change or not to change. The third one is partnership, working together with another person and recognizing them as equal and as also an expert. And evocation, the bringing out of another's strengths and knowledge about the situation and themselves. So another way to think about this is to encourage to explore. So all those together make up CAPE, which sometimes is helpful in remembering about the spirit of motivational interviewing, and that it being a cape that you put around a person to protect them or give them power, like a Superman cape. So I think we've got a little picture of that next. And just one thing to share is that certainly studies have shown that helpers demonstrating the spirit of motivational interviewing in their interaction, then the people they're working with are more likely to change. So just using that spirit is very helpful to people. So our next slide talks about what the literature says. So what does patient-centered care mean to people? So these are some of the things that people find important, and conveying warmth. So that can include smiling, just using a pleasant greeting, using person's preferred name, introducing yourself, shaking hands if that's culturally appropriate, sitting down rather than towering over somebody, facing them, using culturally appropriate eye contact, conveying personal knowledge of the person, and as a healthcare provider, having a professional experience, and if you're using a computer, that you're sharing the screen with people. A well-planned visit includes things like agenda mapping, not interrupting, listening, and apologizing if there's any interruptions. Teaching and clear messages include plain language, teach back, explain what's going to happen during a visit and for any procedures, using images and diagrams if that's helpful, providing information in print and a summary of the visit, also to encourage questions and conversation, and then have a graceful end to the visit. So our next slide is it's based from a large study which is based on surveys of patients seen in primary care. And what matters most to patients, it was participative, provider care, and staff courtesy are by far the most powerful predictor of overall patient satisfaction. So this data is from a survey of over 8,000 patients in a large primary care system in the Midwestern United States. The data was collected over a 2-year period, and there is much more detail in the article about how age, health status, and gender may influence how patients perceive care. And I don't know, I can't see the reference on the bottom of this slide, but it will be in the slides that are in your resource, and I think we're using them in the next slide, so I think they're probably in that as well. We move forward.
Oh, sorry. There you go.
Okay. So that doesn't show it anyway either, but it's Van der Van, and it's Patient Experience Journal 2014, and it will be in the slides. So some additional detail from the survey of what patients meant when they were describing participative care was having confidence in the provider, feeling respected, in being involved in decisions, that the provider was listening, was courteous, and he provided explanations. The next slide tells a little bit more from the same study and talks about, okay, what does staff courtesy mean? So it was determined by two things: overall courtesy, so saying hello and greeting people by name, handshakes when they're appropriate, you know, eye contact, paying attention when people are speaking. And it was also about how they understood and could use the information given to them. So the Ask, Tell, Ask technique has been presented in another of these presentations, and it uses the principles of motivational interviewing to increase the chances that patients will be ready, willing, and able to act on information and or advice. So it involves asking for permission or what the client knows or wants to know, telling the information respectfully, clearly, or in small doses, and then finally asking what they thought or check understanding with teachback. So next we want to talk about a little bit the Stepcare self-management support. So this has been discussed in previous webinars about how self-management support can be stepped up to meet people's needs. So today's webinar is on the first step. So this step, and I'm sorry this slide, it's very difficult to see, it kind of shrunk. But the bottom step is focuses on foundational support and care that everyone needs. So it includes honoring a person's culture, respecting their beliefs and value, promoting health literacy, so making sure people can understand the words you're using, and providing an opportunity for people to be actively engaged. The second step is helping people make plans using the information they have. So this is where brief action planning fits in, and that was presented last week. The third step builds on the others, and some possibilities of this are motivational interviewing, which will be, I think, in a couple weeks. Also working in groups and care management. So as you move up the steps, all the prior steps continue to be used. And then this top step is the advanced approaches. So it's always important to remember that all these steps take place in the surrounding environment, and healthy communities and supportive family, friends, and caregivers provide additional assistance, incentive, and motivation to self-manage.
So thanks, Bernice. So we have to kind of put the presentation together. We kind of got to a place where we were like, you know, we can share a lot of information around what patient and family-centered care is, and I think most of us inherently get the concept of what it is we're trying to do. We can oftentimes at least get a sense of what I would like my experience to be as an individual if I am in that receiver role. But the next step, which is really how do we actually get that into practice? And there have been some really key comments that have come through in the question boxes around sort of the onus can't only be on healthcare providers to be the owners of patient and family-centered care. And I 100% agree. And I think while the providers end up being at the pointy end of the experience because they're the ones that are often in that one-on-one or small group interaction with patients and their families, they need to be supported by a system that is designed to allow for all these things that we know will make a positive interaction that is sort of respects dignity and is culturally safe and allows us to evoke sort of the goals and work of patients and their families and work with those. And if we're working within a system where we don't feel like we have the skills and the tools to be able to do that, if we don't feel like those aspects of care are respected and encouraged, if we don't have the time within our visits with each other to be able to explore those things in a meaningful way, it becomes very, very hard. And I think that's why there's sort of this next step, which becomes, once we come to understand what are some of the various things that go into patient and family-centered care, we then get down to sort of the really meaty work, which is, so what do we actually do to make this part of how we work? And so for me, I tend to reflect on some of the experiences that I've had with some of the teams that I've worked with. And one in particular comes into mind in the work that I've been doing in the recent path around child and youth mental health in the province. And we're working with one of our communities who wanted to try a new model of wraparound care in their community. And it was, there was a foundation to build on of care, of positive or good care that was happening, but they knew that they needed to do more to truly have patient and family-centered care locally. And so one of the key elements of their work was focusing on how they could identify the strengths of the family, and asking and working towards the goal of the family in care alongside some of the medical goals that would be coming into play as well. And so it sounds like a small thing, right, in terms of evoking those goals, but what it really meant was that they had to make some fundamental adjustments around how they assess, discuss, and create care plans so that they could ensure that those goals were front and center. So, as I think as one commenter said, it's one thing to kind of acknowledge that we want to do this, but then we have to sort of look at what are some of the fundamental shifts we have to make in how we design our care plan. Do we even have a field on the care plan to be able to record the patient's goals that is at the same level of what the medical goals might be for treatment, and understands how those things might be supportive or different from each other, and what does that mean for how we need to adjust moving forward? And I think Bernice, you had some ideas as well around how do we look at incorporating patient and family-centered care into our work.
Yeah, so I agree that sometimes there's, we look at the big system things and what can we do, but there's often little things that can be done. So I think it means at every opportunity asking the question, am I doing something with my client and family and not doing to or for them? So as Christina's talked about, ensuring they're involved in care planning. And so some shifts that from hospitals I've heard of is one was moving nursing shift report to the bedside rather than occurring at the nursing station. So that was something really big, but to make sure that the client was involved in what was happening with the next shift. Another one was making sure that patient goals were included in the care plan, and that these were displayed on the whiteboard near the patient's bedside along with the medical goals.
So when we think about patient and family-centered care, person and family-centered care, what are some of the strategies that we can use to try and move towards a patient and family-centered system? And so I'm going to share with you some of the things that we found through some of our work and some of the resources available online. I would encourage folks to kind of type into the question box, what are some of the things that you've tried, that you know about, that you feel, some of the concrete things that we can do to try and move towards patient and family-centered care within our system. So a couple kind of strategies to consider, aspects to consider. Do we have a way for patient and family goals to be documented in our care plans alongside the other information that is there? And do we have a routine way of eliciting those aspects of care from them in times that make sense? How can we ensure that patients have access to information about what the current plan is for care and how they can expect to be involved? And so an example, as Bernice talked about, are whiteboards in hospital rooms that list information on caregivers and tests for the day and where patients' questions can be answered. I've also seen some really interesting examples from primary care environments where there are folks testing out sort of electronic ways for patients to get information on their care and communicate with their care provider. We can look at how we've integrated routine ways to get feedback on how treatments are going, what's going well, what's going less well from the patient's perspective, and what might be able to do or to change. You know, are we asking about what are some of the side effects of medications and looking at how we can adjust those so that folks feel that that their experience they can live their life alongside of the other things that they need to do. Do we know how core support networks exist in the home? What are the support networks for the patient? And is there a way that we can have them involved in care? How might we be able to tap into the resources as allies in the care journey, both for the patients, but as well as for the providers? There's some really interesting stuff that's starting to happen, especially when we look at reaching out to diverse populations and having culturally competent care, where you see whole systems collaborating with whether or not it's faith-based groups or different cultural-based organizations to look at how they can support sort of self-care in the community through these organizations that don't actually require the provider to go out and do these things, but trains up individuals that already work within these communities to be able to support them in ways that include not only the individual but their family and their community as well, so that they have that support network once they're outside of the system doors. Great, and yeah, so some of the things that are coming through really resonate or seems to correlate with some of the things that we're saying at this time as well. So one of the things, and this came up in the questions, is who has the time? And I think whenever we're talking about anything that has to do with some of these upfront investments in relationships, time is always a factor. And it would be an error to not acknowledge that time crunch definitely comes into play when we're looking at patient and family-centered care. And so I wanted to take an excerpt from the Institute for Patient and Family-Centered Care in terms of how they approach time and the time crunch. And what they say is that implementing a patient and family-centered care approach does require an upfront investment in relationship building. Staff must have the opportunities to explore how they can currently interact with patients and families, to discuss and reflect on the value of collaborative approaches, and to build new knowledge and skills. For family-centered care to be effectively implemented in any healthcare setting, staff must honestly assess how they're currently treating their patients and how this can change. Just undertaking this honest assessment is very valuable for the institution. The time it takes to build these partnerships with individuals and acquire the appropriate knowledge and skills will eventually be repaid several-fold when administrators, clinicians, patients, and families have a shared understanding and respect for what each bring to the healthcare experience. The stage is set for mutually beneficial relationships with shared priorities and goals. Time will most likely not be wasted on repetitive, ineffective, and counterproductive activities. And I think this is sort of where the payoff ends up coming into play, is that we predict that if we're able to put in some of that upfront time, we can save ourselves time in the back end by ensuring that what we're doing together is the best thing we could possibly doing. And we're not going to necessarily have to address things 2, 3, or 4 times, because we're, as much as we can, trying to get the best solution the first time and setting people up to be effective self-managers, to be able to live the best life they can given the circumstances that they face. So how do we begin? And you know, one of the simplest ways to begin is really a conversation, and that's one of the things that came through in the comments from IPCC. Conversations with those who receive our services, what's working for them, what's not. Conversations between ourselves as with people within the system around what's working and what's not. And there are many tools that can be used to get patient input, like patient journey mapping, focus groups, and surveys. But there are also the option of just simply starting with a conversation with a patient or family member or a colleague, or practicing observation or shadowing of a colleague or of a patient interaction to be able to get a sense of what the experience is in interacting with our services every day. And for those who like sort of concrete ideas, tools, discussion guides, there are a couple websites you can go to and explore further. The Institute for Healthcare Improvement has some great information, and then of course the Institute for Patient and Family Centered Care has a wealth of tools for folks that want to engage in this type of work in multiple levels of experience, whether or not you're just starting or you're ready to do something a little more in depth. And this is an interesting, so this is there's a feedback, an idea from one individual has come through in the chat. And she says, when I worked in acute care, I developed a practice of starting the day by first introducing myself to the client and then asking what their goal was for the day. Simple but revolutionary. It is too easy to focus on what our goals might be, as opposed to not having the opportunity to, I'm paraphrasing here, and it's fascinating when they don't match at all. And I think that is a fantastic example, and there's actually a whole campaign that's happened in the United Kingdom around introducing yourself as the first thing that you do with a patient and letting things unfold from there. So I know we are about 4 minutes to the end of this webinar, and I wanted to stop there and see if there were any questions, or see if Bernice, you wanted to make any comments.
Yes, no, I don't have any other comments, but I think there have been some great things coming through on the chat box. So I don't know if there's anything else that you wanted to share from that.
I must say, there's a ton, and me getting used to the use of this sort of question answering as was a little bit tricky for me, but yeah, I think there's lots of stuff, and some of it we might be able to look at summarizing and sharing with some of the notes afterwards. Okay, so what are the next steps? We're going to share out with you the handout. We're going to share out with you have the links to some of the tools. Those can go out afterwards as well. And some of you really like the video from Dr. Berwick, and that we can share with you as well. It's freely available in multiple websites. And you can even just Google Don Berwick, what patient and family-centered care really means, and there's a journal article about it as well. And then for those of you that are continuing on the journey of the webinar series, the next webinar happens on October 5th from 12 to 1 p.m. And the focus of that is quality improvement fundamentals for self-management support. And I would imagine that patient and family-centered care will be central to that aspect as well. And please give us feedback. We are quality improvement people at heart. We thrive on the information, especially on any sort of feedback you might have around how we could do this differently or better the next time that would make it resonate for you in a newer, different way. And thank you. I think, Troy, is there anything that I have missed
I
at this
think
point?
you covered everything. Yeah, thank you everybody for joining, and take a look at the resource page to get all the materials that you had given to you today.
Thank you, everybody.
Yes, thanks to everyone.
Bye, everyone.